And the first topic that Dr. Natalie will cover is challenges for HIV diagnosis in the era of PrEP. Please join me to welcome Dr. Natalie.
Hi everyone, good afternoon. So I hope you're still energetic and ready to listen to more about the talk today, which is about how do we manage HIV diagnosis when we're prescribing PrEP, or effectively antiretroviral medication that may affect the test results. So we'll see. So I'm here for the next 20 minutes to talk about three main headings. There will be a poll, so if you would like to take part in the poll, make sure you've scanned the pieces of paper you've been given, so you're ready to go. So I'm going to go through three things in this talk. The first one is acute HIV when your patients are on PrEP and PEP. How does this affect the testing, diagnosis, and your decisions to start ART? And the second one is, how does this affect the management of your patients? And as we've discussed already, has been discussed by earlier speakers, by Dr. Tim Cressy and Dr. Pong Samad about drug resistance. How does this affect it, and how does it affect clinical outcomes? And finally, the important messages about how you as frontline workers or researchers need to be prepared when this area of care slightly changes because of these changes in practice. So this map is really just to show that the numbers of PrEP prescriptions, initiations of all products you can see, so the dark blue here is up to over 1 million initiations, has really risen throughout the world. And as PrEP use increases, acute HIV will increasingly be more challenging to diagnose and also be more detected among PrEP users, not because PrEP or PEP are not efficacious, because they are still very highly effective and we still recommend them, but with the sheer numbers of people starting PrEP and being given PEP, the numbers of these will continue to rise. And so anybody who is working in the HIV field will be affected by this. So first of all, why? Why do we want to talk about acute HIV detection in PEP and PrEP users? Well, because we want to limit immune system injury and also establishment of HIV reservoirs. And also, as has already been mentioned by earlier speakers, we want to minimize the risk of drug resistance and the consequences this has on prevention and onward HIV transmission. So really the point that I want to make in this talk, if you remember nothing else, is that acute HIV is harder to detect in PrEP and PEP users. Many of you will know that recently the WHO has changed its recommendations to include HIV-specific antibody point-of-care testing as a complementary screening tool for the identification of HIV. But it's important to remember in the context of the topic of this talk that these cannot always diagnose acute HIV. So just a reminder that acute HIV includes Phoebig stage 1 and 2, which is up to where 50% of HIV transmissions take place. And so the acute HIV infection stage is by definition the period prior to development of HIV-specific antibodies and usually asymptomatic. So with the current testing technologies, you can then see from this that some people may have falsely negative tests, and I'm sure many of you in this room will already have had experience with having patients who are on PrEP or have received PEP, and you have a high clinical index of suspicion, yet their tests come back negative for HIV. Of course, this is because the detection of HIV is dependent on the levels of HIV viremia, which of course is suppressed when your patients are on PEP or PrEP. So this is really just to emphasize that the WHO recommends HIV self-testing, which you can use not just at initiation, but reinitiation if somebody goes off PrEP and comes back, or for continuation. And it's an additional testing option to complement, not to replace HIV testing strategies, so that it is more accessible, so we can include more people into the testing cascade. However, I have to emphasize that with Dr. Cressy mentioned about CAB-LA, so the role of HIV self-testing in this is still currently unclear. So what HIV testing options are we familiar with at the moment? So this is really just a reminder of what many of you already know. So there's the nucleic acid amplification testing strategy, which detects HIV at a much earlier stage, up to 10 days after the acute infection, and of course has the advantage that it can detect HIV early. However, it is not accessible to most of us in the Asia-Pacific region if we work in low to middle income settings. And so what most of us use is antigen antibody tests, which detect after exposure later at 18 to 45 days, or most of the point of care testings, which utilize antibodies, which may take up to 90 days after exposure. And of course, these have the advantage of being more accessible, they're less expensive. However, they do detect infections later. So how do antiretrovirals, whether it's PrEP or PEP, affect test results? So really three main ways. They either suppress or slow the viral replication and development of antibodies. And you may find that because viral replication and antibody development is different with these antivirals, the detection may occur out of synchrony, which we'll see in one of our case studies today, or you may see false negative results. So this is our case study. So I'd have your voting ready. So we're going to do a vote on this. It's a 20-year-old MSM who regularly comes to your clinic. He reports having condyless anal receptive sex with a single partner, has no clinical symptoms of acute HIV or any opportunistic infections. The day that the patient comes to you is at the end of November. His last unprotected sex was 2 weeks prior, and he says that he's been on regular daily TDF FTC for the last month, and his last anti-HIV test was negative, and so PrEP was started. So he comes to you today, he has no symptoms, his rapid anti-HIV test is negative. However, his fourth generation test comes back inconclusive. So the first question is, what would your management plan be whilst you're awaiting the repeat testing results? Would you continue PrEP for now and see what the results show? Would you discontinue PrEP and see what the results show? Or would you, as a precautionary measure, start ART and then see where things go from there? Okay, so most people went for one, to continue PrEP for now, and we had a few takers for stop PrEP and a few chose ART. So really, the answer to this is there's no exact right answer. It really depends on your index of suspicion. So for inconclusive test results, so in other words, you do 2 tests and there are inconsistent test results, the recommendations are to repeat testing at 14 days with 3 potential management options. So you can continue PrEP. And so the good thing is if it's the test is negative, you have ongoing protection against HIV. However, if it's positive, you've possibly exposed the patient to inadequate therapy and increased the risk of drug resistance, which we don't want. If you discontinue PrEP, this will help you with your diagnosis, but of course puts your patient at risk of HIV. Or you could intensify to triple therapy, which would effectively mean immediate ART initiation if they are positive. However, if it's negative, you unnecessarily expose the patient to a third ART and also make it more difficult to confirm or rule out the HIV infection. So I think the take-home message from this slide really is think about the pre-test probability. And if at all possible, if you have access to nucleic acid amplification testing, try and use this if there's a very high pre-test probability. Okay, so back to the same patient. This patient was started on TDF FTC, and when his tests came back inclusive, he was immediately called back for repeat testing. And both of the tests, the rapid test and the anti-HIV test, which was laboratory-based, came back positive. So you can see here we did a 4th generation test, third generation testing. So at this point, PrEP was stopped. So if you were the doctor looking after this patient, so this is the next polling question, what drug-resistant genes would you be concerned about? So we've discussed this in the previous talks. And what would your next choice of ART be? So these are your choices. Would you go with 1, 2, 3, 4, or 5? So we'll give you a few seconds to think about this. Right, so most people thought probably M184V and K65R, and also many people thought MV184. Okay, we'll see. So we think that the best option is probably 4, and I'll explain why in the next slide. So with this patient, we checked his viral load, which was just over 16,000, and his CD4 was 525, was still okay, and he was started on TDF-FTC and dolutegravir. Genotypic resistance testing revealed M184V, so most of you who voted were correct on that. And of course, you're familiar with this, and it's been mentioned in the previous talks that it suggests a high level of resistance to 3TC or FTC, but increases susceptibility to zidovudine and tenofovir, and also produces low to intermediate resistance to abacavir. I want to point out here that this viral load is in the tens of thousands in the context of somebody who we think has acute HIV because he had a recent HIV test which was negative. So although this is unusual for acute HIV, it's possible because of his partial suppression with the PrEP that he was taking. And you can see that despite this, having M184V on TDF, FTC, and dolutegravir, he was able to virally suppress within 2 months of therapy and maintained a good CD4 level. And so we've talked about what M184V. This is just a reminder of some of the other resistant gene mutations that can be seen in PrEP users and PEP users. So K65R, as you know, is mainly intermediate reduction of susceptibility to TDF, abacavir, and 3TC, FTC susceptibility, and can cause you to be at risk of emergent DTG resistance if the patient is already on a DTG-based regimen. And this number you've already seen today as well. So 148 also confers low-level DTG resistance. And as previously mentioned, you can give this twice daily. So you may be thinking, okay, so you're telling me that I need to worry about drug resistance in PEP and PrEP users who have acute HIV. How common is this really? And I'd invite you to look at the figures from this study, which was published in 2021. And the short answer is that it's actually quite rare. However, if you've seen enough patients, I'm pretty sure that many of you in this room will have experienced this at some point. So in this study, they looked at the incidence of both PrEP and PEP, and they're both less than 1%. And in this study, in the 23% who were found to have new M184V or I mutations, all had received TDF-FTC, and they were able to achieve viral suppression after a median of 112 days. You'll notice that the regimens used here were all darunavir-based because this was the data was collected about 10 years ago, but of course, in current times, we would use dolutegravir. And so really, the message in this slide is that although you do see drug-resistant genes in acute HIV PrEP and PEP users, that it is rare, and to emphasize that the benefits of same-day PrEP prescribing still outweigh the risks based on data we have at the moment. Okay, so in that case, you mentioned about pre-test probability. What should I be looking for? And these are the things that you probably already think about when you see your patients when you're giving them testing. Do they have symptoms of acute retroviral syndromes? Have they had an STI in the preceding year? Have they had a high-risk exposure, so condomless sex with a known case living with HIV who is not virally suppressed? Or did they have their last high-risk encounter in the last 10 days? And if they have, if it's high risk, then they are at high risk of developing drug resistance if they've had partial PrEP adherence, or they had just been started on PrEP during acute HIV. However, if they had not really been taking their PrEP, then it's unlikely that they will develop drug resistance. So many of you may be thinking, okay, well, should we actually be continuing PrEP and PEP then, if this is going to contribute to the drug resistance challenge that we're seeing? And so people have actually studied this. There's been a modeling study done in San Francisco, and what they found is that widespread PrEP use likely will increase the proportion of HIV infections with drug resistance. So it will increase the problem with drug resistance. However, this needs to be balanced with the fact that the total number of resistant infections will decrease depending on the risk behaviors and PrEP effectiveness as well. And I think that this message is emphasized in another great study done in South Africa, where they did a modeling study. But just to mention, this is for a generalized HIV epidemic, as is the case in South Africa, that with ART alone, although this prevents just 20% of HIV infections, it increases the drug resistance prevalence to 6%. With PrEP alone, you get increased numbers of HIV infections slightly and a similar number of increase in drug resistance prevalence. But in combination of ART and PrEP, you end up preventing overall about 35% of infections, however, at the cost of a slightly increased number of drug resistance figures. So this is my last 2 slides now. One of our previous speakers talked about cabotegravir, which is, as you know, an intramuscularly delivered pre-exposure prophylaxis option. And we know that this is safe, highly effective, shown famously in the HPTN 083 and 084 studies, which I know many of you in this room were involved in. And we know from qualitative studies that it is well accepted. However, the challenges and future studies that may be needed when we look forward towards implementing this is we know about the high cost and the logistics of implementing. Dr. Linda talked about the large volume that is going to be needed for injectable ART. And also, there is some evidence to suggest that high BMI may alter the PK and drug levels, which may affect the candidates that we need to be thinking about in selecting for safety in the use of cabotegravir. And also the role of HIV self-testing. Can we be using this with long-acting PrEP? And also, as mentioned in this talk, drug resistance. So in the 083 study, it's notable that INSTI resistance was detected in 4 of the CAB-LA group who acquired HIV, and this was in the 148 genes and the 263K genes. And also important to remember that infections within the first 6 months after CAB-LA are associated with drug resistance. So I think this figure really summarizes what has been mentioned by the previous speakers as well, that although we were thinking about PrEP and this talk is about PrEP and PEP, really it's one continuum, and resistance of to a medication on the prevention side or the treatment side automatically affects this whole cycle. And so what implications does INSTI resistance have in an age where most countries now use INSTIs or are moving towards using INSTIs as a first-line ART, and of course the risk of onward transmission of INSTI resistance. So really this is the end of my talk. I really have 3 take-home messages I want to communicate to you all. Number 1 is that particularly with the point about HIV self-testing, that it can be used to adapt to your current testing systems, and it can be complementary to trying to simplify, increase access for our service users to deliver PrEP. And although acute HIV does occur in PrEP and PEP users and can lead to drug resistance, it's uncommon, and with the current evidence that exists, it is manageable. Regarding to the HIV laboratory diagnoses, we know in this age where there may be different test results in people who are PrEP and PEP users, maybe a review of algorithms is needed, and perhaps it is useful to review how you manage inconclusive results in your clinic to ensure that everybody is on the same page and aware about what needs to be done with those test results. To always remember about risk-based testing, and if your risk of suspicion, your suspicion of HIV infection is high, your index of suspicion is high, to access NAT testing if possible. And finally, the challenges that we still have going forward with CAB-LA and drug resistance. This is the end of my talk. I just wanted to invite you, if you are going to APAC or thinking about going to APAC, that we will be having a Cascade of Care multi-stakeholder meeting in Hong Kong. So feel free to join us or speak to any of us, Annette Sohn or Dr. Tanya Wee, who are leading the session in Hong Kong. And also a final word, just if any of you are interested in working with adolescents or setting up a youth advisory board, we have a group of our youth leaders outside in one of the booths that would be very happy to speak to you. Thanks for your attention.
Thank you. Thank you very much, Dr. Natalie.